Thank you so much, Josh, and I'm privileged to be here, and I appreciate the invitation that you provide every year, because looking at this room, Josh, it gets bigger every year. This is very impressive. And what I'm looking at right now is the future of what will be, I truly believe, the best healthcare system in the world, full stop, period. And what I want to talk about a little bit today, is a personal experience that I've had over the past 40 years. This past July, I celebrated having my Ontario General Medical License for 40 years, and I've been very privileged to have a variety of experiences in the Ontario health system. And I wanted to kind of describe a few of those, because you heard from Minister Hoskins today. You saw the passion that he brings to the concept of patients first, of changing our system to put patients at the center of care. The sense that both he and I have is that our work is far from being done, but it's close to a transition point. You know, God willing, the reintroduction of the Patients First legislation, Bill 41, with passage, with the transition to a new LHIN model and a new sub-LHIN model. We believe that's going to happen, and we believe it's going to pass to you. An opportunity and a novel platform for quality improvement close to the context of your work, in your workplace. And what I want to try to do is inspire you today to think about your personal opportunity to create change and quality by telling you about a few experiences that I've had during my career, my 40-year career, working in a variety of roles in the Ontario health system. And you know, one of the earliest experiences I had was working as a primary care provider in Brampton, Ontario. And one of the first experiences I had in that as I joined a group in Bramalea was to be told that I had to go and speak to the head of family medicine. I'm not going to mention his name because many of you will know him. He's still around. He's still active. He's a wonderful, wonderful leader of quality in the Ontario health system. And I sat down in his office as someone who had had my general license for about 2 or 3 months and was literally new to I just learned the geography of where Bramalea was trying to figure out how to get there for obstetrics from the west end of Toronto, where I was living at the time. And he sat me down and he said, you know, you have a magnificent opportunity for a wonderful career. And one of the first things he says, and you know, after a year or two, you're going to have an opportunity, you won't believe this, to buy one of those mansions down the street. That is $100,000. You're going to be able to afford it. Anyway, that was not really what I'm here to tell you about, but as I was thinking about this, it was a bit of an anecdote that went with it. But what he said was, you're going to have a magnificent, you've joined a great group here in Brampton, and what you need to know as one of the members of the family practice department, Peel Memorial Hospital, is that you have responsibilities and accountabilities to this community. He said your practice is going to explode. It'll be a full practice in no time. But as you practice, you have to remember that you're accountable as one of the members of this community that will deliver babies. All our primary care providers up to a certain age deliver babies. All of us work in the emergency department. All of us look after our patients in hospital. In fact, it's interesting, as I learned about the way the hospital focused around primary care, when I went to do surgical assists in the operating room, I learned that operating time at Peel Memorial at the time was not assigned by surgeon. It was assigned by primary care group. So when I went there, I'd assist a surgeon doing a total hip replacement, a spine surgery, a hysterectomy, a cholecystectomy. The surgeons would change. The surgical assistants, who were the MRPs for the patients, stayed the same. And he also told me something that stuck. He said, we're going to have a way of defining your accountability. He said it's very easy to measure. We're going to look at the number of patients who come to our emergency department at Peel Memorial Hospital for conditions that aren't life-threatening, that have your name on the document as their primary care provider. First lesson. When you're thinking about quality and you're thinking about accountability, think about measures that count. Think about measures that immediately when you hear them, you recognize it's going to have an impact on your behavior. It's going to be something that's rational. It's going to be something that you can alter through the way that you and your group and your colleagues actually provide care that you can have impact on. And I think when we think about quality and when we think about the opportunities that we have to create the best healthcare system in the world here in Ontario, that's one of the places we start. We start with the issue of we have to measure quality effectively. It has to have something as a measurement that means something to providers, and it has to be a measurement that means something to patients, because he was telling me, you're responsible. You're responsible for ensuring your call schedule works well, that you're responsive to patient calls whenever they're coming in. We're going to hold you accountable. That meant something to me. It meant something to our group, and believe me, we looked at those numbers very, very carefully because we were told what they were. And you know, I think that's one of the things that Patients First is trying to engender, is that sense of mutual accountability to a defined group of patients that somehow we've lost a bit. And the sub-LHIN areas, the sub-LHIN regions that our LHIN CEOs are defining for us right now, they've given us their first draft. Many of you have seen them. Try to bring us back to this system of rational geographic accountability. I knew who my patients were. I knew who my group's patients were. I knew who my coverage group's patients were. I was capable of looking after their needs when I was on call. And I was capable of affecting how many of them went to the emergency department for reasons that weren't really rational. And you know, the sub-LHIN region that we're talking about, trying to bring that same sense of planning and accountability to providers in that area, that's something that we're trying to replicate, that meaningful measurement aspect and the meaningful accountability that says we can impact on this. The second thing that I learned from that initial conversation was the crucial importance of clinical leadership. Because this wasn't a conversation that was happening to an administrator of our group. This was a conversation that was happening clinician to clinician. And that sense of accountability, that sense that if this hospital is going to work well, if this community is going to feel like it's got good clinical care, we doctors, we nurses, we clinicians are responsible for that. And that engagement of clinicians in thinking about how a regional system of care provides access and provides accountability, I think that's something that we've lost a bit, and I think that's something that Minister Hoskins and I feel needs to be regenerated. I know through conversations with Sarah Newberry, with Jessica Hill, the Ontario College, feel strongly that that sense of a patient-centered medical home. The patients know who's responsible for quarterbacking, organizing, who they turn to when they're ill, who they turn to when they need access to the system. That sense needs to regenerate again. On a regional basis, it's present in many areas, we know, of our province, but it needs to be regenerated as an absolute expectation of healthcare in Ontario. So, you know, that was the first lesson I had. The second lesson was one that, you know, you can all make a difference. And I came back, I went away and did some surgical training and came back with the challenge of trying to think about how treatment of patients with musculoskeletal tumors in Ontario, sarcomas, could improve, and how we could implement a system of care that would be regional, generalized, and could improve outcomes. And you know, you might think when you look at problems of quality improvement in your domain, you might think, how can I possibly make a difference to this? And that was certainly the sense that I had. You know, it was sort of an insurmountable target, it seemed. When we looked at care, it was distributed. Everybody was looking after patients with these problems. And the care seemed to be terrible. And when we actually got back to that first principle of let's define a metric, let's actually look at how we describe something that's a number that can actually reflect reality. Indeed, looking at the Ontario Cancer Registry, that wonderful resource that was underutilized at the time in Cancer Care Ontario, we found that indeed most patients treated with sarcoma in Ontario were having terrible outcomes. They were having local tumor recurrences. I won't bore you with the details. Defining, as Health Quality Ontario has taught us so well, across everything we do, a metric that actually reflects a real outcome, not a process outcome, wherever possible, a real outcome, is one of the first things that really redefined sarcoma treatment in this province. Along with a bunch of other people, we were able to go to meetings across the province, to hospital meetings, to just about anybody that would listen to us talk. We would go to places and we'd say, look, here's the results they're getting in Boston, this kind of cure rate, this kind of control rate. Here's what the results are in Ontario. It became obvious that we had a huge challenge, and we had an opportunity. And just like we do in Ontario, where we can say, here's the kind of care that's being provided by excellent family health teams, by excellent family health organizations, by excellent CHCs in this province. Here's the kind of way we define their care. This is something that we can do everywhere in the province. So thank you, I agree that deserves applause. It is something that we can do. Approximating best practice and evaluation of practice outcomes with metrics that mean something to patients is something that really starts our journey, not on a provincial basis. We can measure things provincially, but you can understand what those provincial measurements mean in your local region and use those to speak to the challenge of improving quality in that area that you're responsible for. You know, it was easy back in those days to get metrics that meant something, the thing I was interested in, which was cancer care. It's possibly a little more difficult to get information that reflects what we're trying to enhance with patients first. And when we're looking at the Sub-LIN regions, one of the things we want to make best in world, best possible patient experience, so that we not only have excellent healthcare outcomes, but we have individuals who understand how they access our healthcare system, who understand what their patient-centered medical home means and how it operates, and who have a sense of confidence that the system is there when they need it. And you know, Ontarians have that sense of confidence today. Health Quality Ontario has shown us that about many parts of our system, about cancer care being one, cardiac care, hospital care. Not that we've solved all the issues, we haven't, but Ontarians have more confidence in that part of the system. Bringing that sense of confidence in a uniform basis across the province, the patient experience being such that people feel that when they need access to the system, it's there for them in timely fashion, in the way that they can access the way they want to access it, and that as time moves forward, we will move forward with the time. We will allow access to be by technology where appropriate, that we'll be able to be making appointments with our primary care providers by email. That will be part of the solution that contributes to the patient experience, that patients will be able to get access to opinions from their care providers by secure email, and that physicians will consider that as part of their practice and they'll be paid appropriately for that. These are things that we need to consider. The whole gamut of change that we need to create a system that engages the way that patients want to encounter our system and speaks to patients about the way they want to be served. And we think that bringing the patient experience into our system, how do we do that? Well, our sense is that one of the most important ways to do it is to simply ask patients how satisfied they are by their level of service. And this is something that we will see happening over the next year or two, is asking all patients who are rostered to primary care providers across the province, since one of the things we want to do is enhance patient experience with access to our system through a model of a patient-centered medical home, to survey a whole lot of Ontarians. So I think one of the things that bothers us most about Ontarians in the healthcare system, working in the healthcare system, is that statement that we hear so often, that we rank 10th out of 11 rich countries in terms of providing adequate access to our system. When we talk about things like having to visit emergency departments for situations that could be managed in primary care, when we hear about access in timely fashion to primary care. So we think that's a situation that can't be present, and the future if we're truly going to be a leading jurisdiction in our healthcare system. So we're just going to ask Ontarians. We're going to start off by asking them probably 3 simple questions. Can you get access in timely fashion? Do you ever have to go to the emergency department for conditions that could have been managed by your primary care provider? Do you have access? Do you understand what to do in the evening times or on weekends if you need access to the healthcare system? And we'll just ask Ontarians how satisfied they are by those kinds of access issues. So those are pretty straightforward issues that, back in the day when I was in primary care, I think just because it was smaller, just because it wasn't so technologically complex, 40 years ago, this system used to probably respond a little better to the patient experience, and trying to regenerate that in a way through a model like the patient-centered medical home model is something that Patients First is all about. The other thing that Patients First is all about is organizing on a sub-LHIN regional basis and a LHIN regional basis where appropriate. Implementation of models of care that deal with highly prevalent conditions that Ontarians tell us are poorly managed today. So what's the second most common cause of disability in Canada today? Who knows? I'm an orthopedic surgeon. That's your hint. Back pain. Thank you. Back pain. So back pain. And the story about back pain, the typical story that I heard when I was the CEO at a hospital was I've had back pain for 6 months, and I've been waiting for an MRI at your hospital for 6 months. And then I'd often hear, I've had back pain for a year, and I waited 6 months for an MRI, and then I waited for 6 months to see one of your neurosurgeons. When I saw your neurosurgeon, a marvelous guy, did a very careful assessment and told me that I didn't need to see him, and there was nothing he could do for me. And we know that's a very prevalent outcome. And one of the terrible things, it's terrible that somebody's had pain for a year without any instruction, without any treatment for it, waiting for a couple of things to happen. What's even worse than that is during that time, they've had a high probability of being addicted to opioid medications while waiting for those 2 tests to occur. We know that about 20% of people with chronic back pain are at risk, dependent personalities at risk for addiction if they're given a week's worth of opioid. Now, what's the answer to that? Is the answer to that to invest in more MRI scans? Is to invest in more neurosurgeons? We need more neurosurgeons. We need more access to neurosurgery. We possibly need a bit more access to MRIs. But what we really need access to is evidence-based care for all Ontarians that have prevalent conditions like back pain, where we know there are answers based on Ontario data that are far more effective. We know that 95% of people with back pain will respond to patient education, structured exercise programs, and most especially modification of lifestyle issues that have been provided by programs like the ISAAC program that's currently operative in Thunder Bay, Hamilton, Toronto, that's starting to expand to London and Champlain. We know that patients who are managed in that way avoid disability, avoid waiting for MRIs because they don't need MRIs in 95% of cases, and don't need to see a neurosurgeon, can continue work with structural modifications to the work they're doing if they're physical laborers, but can stay at work, stay active, and avoid opioids, avoid waiting for tests that are really not necessary. And why aren't we doing that now? Why do we have so many people who are waiting off work, et cetera? It's because we haven't thought about management of highly prevalent conditions that can respond to therapies. In this case, education, physical therapy, physical instruction, exercise therapy. We don't have therapists in our primary care system, not enough therapists. The most common cause of disability in Canada is mood disorders. And we know, looking at Canadian evidence, that if we compare various modalities of treatment, most moderate up to many severe forms of anxiety and depression respond extremely well to structured psychotherapy provided by a variety of therapists in the primary care setting. Could be nurses, could be social workers, could be psychologists, could be trained lay people, could be delivered over the phone, could be delivered online, but structured psychotherapy is generally not available to Ontarians unless they have access to private insurance. Not even all people with access to private insurance have access to structured psychotherapy. Another example of a highly prevalent condition that results in people waiting for long periods of time to see psychiatrists, results in people being on pharmaceuticals they don't necessarily need to be on, because we haven't organized our primary care system in a way that allows people to get access to therapies. Well, that's part of Patients First. Part of Patients First is to think about the patient-centered medical home in terms of access to the individual who will provide them with understanding of the way they manage the system in addition to diagnosis and therapy. Also, equitable access to the kinds of therapies that we know, based on Ontario and Canadian evidence, make a difference for common conditions. And you know, some people who are fortunate enough to be rostered to family health teams, for example, or CHCs, can get access to these therapies. But we have to think, as the patient-centered medical home gets redesigned and rethought through, under Patients First, on a sub-LHIN regional basis, how every Ontarian who has one of these two highly prevalent conditions gets access to therapy that allows them to stay at work, to avoid drugs, to be productive, and to avoid waiting for investigations and opinions that they really don't need to wait for. So we've got some work to do. And what Minister Hoskins and I feel strongly, what we're having is an opportunity for transformation. There's going to be a period of transition. Undoubtedly, we have some folks in the community care access centers in the audience. We recognize just how anxiety-provoking this is. Employment's going to change, the employer's going to change, work will remain the same. There'll be that period of transition. But after that period of transition, that's when we're handing it over to you. We need to make some structural investments like the therapy investments that we're talking about here. But we also need to hand it over to you folks, because you folks are the quality champions of the Ontario health system. And you folks can all see yourselves within a role, within that sub-LHIN region or that LHIN or that provincial program, wherever it is that your expertise lends you, to identify the metric that makes a difference to your patients, hopefully not a process indicator, but a real fundamental outcome indicator, like do you have to go to the emergency department, because that I learned about when I was starting practice, or things like we learned in cancer were so important to measure. And you know, sometimes it seems so daunting when you're in a hospital or you're in the community and you think about what you want to accomplish, and it just seems like such a daunting challenge, so much complexity. But you know, if you start off with those basic steps, if you think about things that are important to you, how you measure them, and crucially, things that are important to your patients, that really resonate with the people whose experience we want to enhance. And that's why I know from today's HQO forum how important the patient experience has been, how moving some of the work that patients have described to us has been. This is an essential part of Patients First, is understanding the patient experience, measuring the patient experience, and having clinicians understand their responsibility for improving it. So the platform is going to be launched. It'll be launched starting in spring of next year through summer of next year, the Patients First platform. The sense of clinical engagement, the sense of management of prevalent conditions, the sense of opportunity for innovation, the sense that you will all have as champions of the quality agenda, to work within this new platform where you can affect change, where we'll be looking to enable change. Leadership in the LHINs, the new LHINs that comprise far more CCAC employees than they will current LHIN employees, will be looking for opportunities to challenge, looking for opportunities to do things differently. And what a fertile environment to have 14 LHINs looking at achieving outcomes that we'll look at as provincial outcomes but undoubtedly looking at doing it in 14 different ways. And within Sublands, looking at doing it 70 different ways, with us measuring the outcomes and looking for best practice. So Ontario is about to become a fertile platform for innovation and opportunity. And I think the thing that we all need to keep in front of us as champions interested in enhancing the quality is the fact, as Josh said, is improving quality is never good enough. Our patients in Ontario deserve the best health system in the world. This is our opportunity to deliver it. Thank you for being here today. Thank you, Josh and Andreas, for the opportunity to chat. And look forward to working with all of you in creating the best system in the world. Thank you.